that the episode begins with a live birth trigger. The trigger ends with a discharge, but the episode truly ends after the window of the 7-day window post-discharge, where we'll be accumulating additional data, and we'll have additional data to give to the institutions even within the 30 days post-discharge. And you can see the kinds of things that go on. You have intensity of care, different billings, the respiratory support, professional claims, lab claims, medication use, etc. You have episode adjustments we've talked about again, severity of the case, the fact that the patient gets transferred, and additional clinical factors such as just gestational age. So those are the big picture items. And let me turn this back over to Dan to get into some of the DRG and other episode adjustments for involving with this. Oh, I'm sorry, there's a question. Good. Well, we'll stop for a second. Question. You're off now. Button here at the bottom. Here we go. The continuation of, why don't we look at continuation of breastfeeding? Yeah, you know, we have to pick different things at different times, and I'll be honest with you right now, we're doing in the Medicaid pay-for-performance program for hospitals, we are not a very breastfeeding-friendly state, and so we're going to pick our targets one day at a time. Right now we're focusing on the hospitals, but you're right, long-term sustainability of the breastfeeding is important, but you have to start somewhere. Our breastfeeding rate in the hospitals range from 0 to 40%. There is quite a bit of variation. So right now we're just looking at the hospitals as our starting point.
Hey, Bill.
Richard, yeah.
7 or 30 days post-discharge. Describe that again, because the 7-day post-discharge and readmissions you are going to be held accountable for in the total cost burden.
Correct.
What's the 30-day? Separate the two.
Okay, a lot of episodes we look at, 30-day readmission rates. That's kind of a standard. We had a lot of discussion with Witt and his colleagues about what's an appropriate metric, what's an appropriate kind of boundary. And the group fell on 7 days because that could be for an early discharge or bad handoff. 30 days is interesting, but the group settled on 7 for accountability, and at this point we'll be looking at data. In addition, I think we had some data where the total cost of the episode, if you took the line at 7 versus 30, didn't vary that much. So that's where we settled on 7.
30 is a data acquisition point. It's not an accountability point.
Correct.
Is the accountability point.
Correct. That is correct.
Okay. The PAP is shared between the hospital and people providing neonatal care.
Correct.
Charged. 7-day window. That goes back to Andy, who's now the PAP. The baby's coming back to see him within 7 days. What's his accountability?
Okay, let me figure this out here. Let me get this clear. We have
neonatologists don't follow up all the babies 7 days post.
I understand. He
does.
Make sure we have a clear discussion here. The child leaves a nursery or an NICU. In level 2 nurseries, and some of these episodes include care at level 2 nurseries. In fact, one of our colleagues was a level 2 nursery doc who cares for the child in the nursery and then sees them in their office. That's a continuity of care. Now, in the more elaborate and more severe cases, the child leaves the NICU and goes to a community receiving physician. The NICU has some responsibility to make sure there's a good handoff. So the 7-day window goes back to the receiving the cared NICU. On the other hand, as we move into medical homes, the medical home would become accountable for the care of the child once they leave the NICU. It's a different framework, a different discussion, but that's where it plays out.
The only thing I'd say there, excellent questions, because there was a really lively discussion In other words, if a baby is discharged at, a 29-weeker is discharged at 37 weeks, and the Lasix stopped one day before discharge instead of, say, a week before discharge to see how the baby's going to do, well, then the neonatologist has some culpability in that visit. On the other hand, if it's RSV season and they get readmitted at 25 days, then that probably has nothing to do with the discharge. It's about 3.5% of babies in this group are readmitted, which really is not a very high number and probably won't make much difference. And so that's the number that everybody settled on.
I'm an ID doc. I know that some of these babies that are vulnerable are going to go home and get influenza or RSV in 48 to 72 hours. It's not going to be 7 days. This has the ability to sort that out basically by diagnosis to say, baby goes home. Yeah, we've asked the parents to quit smoking. They don't. There's kids in daycare. They come home, RSV or influenza. Vulnerable baby gets sick. Does the system allow, that's not an issue in which the neonatologist or the hospital that discharged with clear instructions, good communication, excellent handoff to a pediatrician who's monitoring that. But pediatricians aren't going to go home with all their patients. Does the system allow for the accountability that is going to happen next winter? I promise you. And it's going to be more than a few times. How does the system handle that scenario so that Andy and the pediatricians aren't punished and the hospital and the neonatologist shouldn't be culpable?
Yeah, the whole readmissions discussion is complicated. There will never be a perfect answer. On the other hand, everybody's at risk at the same level, more or less. We have the same discussions with all-cause readmissions in the adult world, in the Medicare world. And in fact, every hospital in the state right now is being reviewed / assessed / potentially incentivized or penalized for Medicare readmissions, all cause within 30 days. Having said that, the Medicare program has made some adjustments in what is considered now a readmission. So they've gotten rid of things like car accidents and burns and so we can reflect on this. Will we get rid of every potential avoidable admission? No. We want to make it fair. And at the same time, we have to make it a manageable system as well. I don't know the exact answer for you right now. Right now, we have not included, it's an all-cause readmission framework, but we'll certainly be willing to reflect on that moving forward.
I'm just thinking about UAMS. I mean, our full-term neonates, about half are very high risk. Either they have anomalies or infants of diabetic mothers or some risk factor that puts them at the high risk of needing transfer. Is that transferred to another hospital or transferred to the NICU?
That's transferred to another facility. And it gets into not necessarily the high-risk environments, but what's happening at level 1 nurseries, level 2 nurseries in terms of percentage transfers, that kind of thing.
So Bill just walked through page 23, which outlined 3 types of episode adjustments. And I'll walk through 2 of them right now just to give you guys a sense of how that works. On page 24, it's the first type of episode adjustment is for severity level. And this is above and beyond what we've already done in terms of the segmentation across the different APR DRGs that we walk through. As I mentioned, within each APR DRG, there are further severity classifications. Most APR DRGs have 4 severities, with 1 being the least severe in that APR DRG and 4 being the most severe. So we just picked 1 here to show you on page 24. This is for a particular DRG. You can see the 4 severity levels within DRG 634. You can see the share of neonatal episodes across those. So for the 36% of neonates in this DRG category are classified as severity 1, 42% as severity 2. And you can see what the historical costs are across these severity levels. So clearly the severity 1 babies are less severe. they cost the require fewer resources, whereas severity 4 is the most severe, and the average across this one is 10,000. So, without getting into all the details, essentially, the payers will be looking at the severity levels and making adjustments to account for if a facility, even within DRG 634, has more severity 4 babies than severity 1 babies. There's an adjustment to account for the fact that even within this clinical bucket, severity 4 babies here cost 5 times as much as a severity 1 baby. So that's one type of episode adjustment that's done, and the company 3M that makes the APR DRG has done, again, lots and lots of analysis to help inform where these severities are set. On the following page is the second type of episode adjustment, transfer cases. And remember, in the episode right now, as Bill mentioned before, transportation costs are excluded. However, when we look at the data, even after the payers account for the clinical adjustments and the APR segmentation we talked through, transfer cases are still more expensive, all other things being equal, than non-transfer cases. And so in discussions with our clinical advisors and others, there is some discussion of, in some cases when you have the neonate being transferred, there's increased risk from the actual transfer, even if they have the same, clinical diagnosis code. And when you're transferring between facility, there is variation in management. So if a baby is transferred with 5 days after birth to a higher acuity facility, what happened in those first 5 days sometimes varies depending on the facility in which the delivery occurred. So there is going to be an adjustment for that. And if you look at page 26, these aren't the exact adjustments, but it's some data to illustrate. These are the 7 neonatal episode segments that we highlighted earlier, segments A through G. And you can see on the right-hand column, on average, the number here is the percent increase in cost that we observe historically for a transfer versus a non-transfer, even when you control for a bunch of the clinical factors. So an episode segment, D, for example, a transfer, all other clinical diagnoses and being equal, still costs 60% more than a neonate that was not transferred. So the payers are going to be trying to account for this to make sure that as much of the care delivery pathway that kind of was encountered is really built into the adjustment.
So what's the control group for slide 26, right-hand column? What's the control group there? What's the denominator?
It is comparing the average costs of babies that have been transferred against the average costs of babies that have not been transferred, assuming literally everything else in the claims are basic. They had this.
Sounds like an apple over an orange to me.
Can you say more?
I don't understand why that's the control group. You're comparing a sick baby with a non-sick baby, same weight category?
No. Yeah, no.
Clarify that for me.
Yeah, what's happening is you have kids in these episode segments, some of whom were born in the hospital, they're cared for, they never get transferred. You have others of that segment that get transferred. So you're comparing the kids within the same segment, whether they've been transferred or not. So the group that gets transferred tends to have a higher cost.
As an example, if you look at the claims and looked at 2 babies, and they have basically the same ICD-9 codes and the same RDS, and you'll see 15, 20, 50 different diagnoses, and let's say they're all relatively the same, and let's say they had relatively the same gestational or birth weight. Even once you look at similar populations like that, when a baby has been transferred, they still end up costing more. Even when the claims, basically the claims history is, and so this is part of the feedback from the work group. Part of the discussion with clinical advisors and others was that we're trying to figure out how to adjust for that additional cost that comes from the transfer, even when the other clinical factors are relatively.
And I think we haven't brought it up. We think we ought to talk about who's the PAP. So let's say a child is born in City A, and it's a level 2 unit, and then gets transferred to a level 3 unit. What it turns out to be is the PAP is the level 3 unit. It's not the level 2 unit. And the costs from the level 2 unit are included in the total cost of care. So it's actually protecting, this transfer factor is actually protecting the higher level institutions, the more sophisticated units who are receiving the kids from the outlying hospitals, because you're going to be accountable for the total cost and the costs incurred during the care of the child.
Yeah.
I would assume, therefore, that the quicker that transfer occurs, the lower the cost differential. So this is a pro-transfer. I assume that this is going to be a driver to promote earlier transfer.
Yes, absolutely, Bill. As you know, and you're absolutely right. It is comparing apples and oranges, and that's why there's an adjustment there. And Dr. Palmer actually published on that 4 or 5 years ago, looking at incidence of IVH in outborn versus inborn infants. So that's the kind of thing that we're looking at.
Compliment you on the transfer adjustments, the only thing that makes sense. But my question is stratification between major anomaly. I mean, there will be obviously definitions that will be provided, but I can tell you, and Whit will verify, a huge difference in a major anomaly for cost being a diaphragmatic hernia versus a VSD. So will there be a provision of detailed major anomalies with enough confidence for everybody involved in this that the stratification does not automatically give you a selection bias?
You know, the two you just discussed, one of them, if they require surgical repair, that's probably a different episode or a different segment. So
separate.
There are some segments there that would probably fall into a different segment population.
Okay, and for now probably would be excluded if you go down to that
Correct.
level.